Hello, my name is Dr. Christopher Blackwell. I'm an associate professor, acute care nurse practitioner, and program director of the Adult Gerontology Acute Care Nurse Practitioner programs within the Department of Individual, Family, and Community Nursing in the College of Nursing at the University of Central Florida. I'd like to welcome you to a three-part narrated PowerPoint series covering some amazingly important concepts related to care of the patient in trauma. This particular lecture is quite large, and it is one of those lectures that we've got to know. As an acute care nurse practitioner, you've got to know how to recognize trauma, you've got to recognize how to treat trauma, how to prioritize during trauma, and you're going to really need to know these concepts. They're heavily tested on the board exam. I'll try to focus in on what areas I know are definitely more focused on the exam than others, and that hopefully can give you some hints for what you need to know for this particular unit of instruction. The other thing is this is really designed to complement your assigned reading. This lecture material is going to really focus on emergency management and stabilization, and then your assigned readings for the class are going to go more in detail regarding the intensive care management of trauma patients. So you need to do both. Obviously, you need to listen to these lectures, you need to read your assigned readings out of your textbooks, and then you also need to read any supplemental articles or readings or videos that I might post in the discussion or actually in the course module. So take a look at that and keep that in mind. So in this very large unit, we're going to discuss overview and emergency stabilization. We're going to talk about major systems. We're going to talk in detail about traumas related to the head and the spinal cord, the chest, the abdomen, and some musculoskeletal related injuries as well. And that usually will cover things like compartment syndrome, fractures, blast and crush injuries, and the crush syndrome. We are going to talk about burns and a little bit about shock. You've already had shock in your Acute Care 2 course, so we're just going to kind of give an overview of it, a little bit of a refresher here, not too much detail on shock, but we will talk about it. And then finally, we will have a lot of discussion of diagnostic imaging and what are some of the things that you'll see on some of the major films for patients who experience trauma. So we're going to start with discussing trauma in general in adults, all right? So that's going to be our very first component here. So remember that there are socioeconomic forces that do play a major role in who has traumatic episodes, who has these traumatic events. And research tells us that the more people are impoverished, the more likely they are to actually die from trauma, but they're also more likely to experience trauma. And there's lots of reasons for that. That's because these people might, for example, live in areas that are more prone to violence and more prone to things like gunshot wounds or stabbings, things like that. Or maybe they lack formal education and things that allow them to know about preventative strategies and things to avoid and how to correctly, for example, utilize seat belts and all that good stuff. So there are lots of socioeconomic players that come into play when we're discussing trauma and who is at more risk. Now, the major deaths that occur from trauma in order are going to be traumas related to, first and foremost, the head, right? Remember that the cranium is a closed vault with basically three things in there, right? We have brain tissue, we have blood flow and blood vessels, right? And then we have cerebrospinal fluid. The chest, which obviously is our major pumping area. So if we get, for example, a major injury that tears the aorta, dissects the aorta, or punctures the heart, Obviously, that is going to put us into immediate cardiogenic shock, and then major vascular injuries that cause us to bleed out. And we can think of, for example, a neck injury where the carotid might be laxed, or you think about a long bone fracture where the femur might be fractured, and unfortunately, it compounds through the femoral artery, punctures the artery, and the patient bleeds out within minutes, right? So those are examples of, vascular injuries, which are going to be the third leading cause of death. Let's talk about trauma systems and triage. In a well-run trauma center, the critically injured patient undergoes a multidisciplinary eval, which is oftentimes truncated, and diagnostic and therapeutic interventions that are performed with smooth transitions between the ED, the RAD suite, the operating room, and the post-op ICU setting. Of course, that's an ideal environment. We don't usually get an ideal environment in healthcare. Unfortunately, we're stuck with reality where some of these lines can blur, and we're doing, for example, CPR on a patient, and in comes the portable chest X-ray technician to take the X-ray, and we have to stop giving chest compressions for 10 seconds, whatever it is, so we can set the patient up and get a film, because maybe the patient has a blast injury where there's shrapnel or something that we can't see, and then we get an X-ray and we can see that. There is some principles that we follow. These are ATLS guidelines, which are our trauma life support guidelines. Injured patients are assessed and treated based on their presenting vital sign values, mental status, and mechanism of injury, because the mechanism of injury will actually predict mortality and morbidity. So that's going to be something very important for us to assess. And obviously, when we're triaging, not everybody is going to be able to make it. Not everybody's going to live in, for example, a mass casualty event or a mass I hate to say it, but terrorism event or something like that, and unfortunately we have to make decisions based on the likelihood of a patient being able to survive. And then the age being greater than 65 is also a major risk factor for mortality. So our geriatric patients, we're going to have a specific part of this unit where we're going to talk about geriatric trauma, but our older folks that experience major traumas are much more likely to die. The primary survey, let's talk about that. So patients come in, they're transported to EDs, and most of those EDs are not trauma centers. In Orlando, we have one trauma center. In Lakeland, they have one trauma center. In Gainesville, one. Tampa, I believe, just one. So the vast majority of the time, we are going to, make decisions in that environment where we're going to have to decide, are we capable within this particular environment to treat this patient? And one of the most deciding factors for that is going to be brain injury and potential for brain injury, because one of the important distinguishing characteristics of a level 1 trauma unit versus, let's say, for example, a level 2 is whether or not there's a neurosurgeon available at all times. So if there's not a neurosurgeon who's there who can actually perform an emergent craniotomy on a patient, if the patient needs that, then he or she needs to be transferred out. And I remember we would get traumas to Florida Hospital when I worked as an emergency room nurse, and not all the time, but every once in a while, maybe once every couple of months, we would get frustrated because we would like, man, this really shouldn't have gone to us. This should have gone to ORMC. This is a little bit more than we can handle here. We don't have thoracic surgeons waiting in the wings and neurosurgeons waiting in the wings ready to take over care. So that's important. So we would get angry at EMS when we really shouldn't have. A focus history obtained, I always make a comment that EMS, unless you're out there working in the pouring rain and you're getting mud all over you and blood all over you and, really working in the trenches like those guys do, we really should not. And I mean guys and gals, we should never criticize them. I used to hate it when I worked with nurses who would, paramedics don't know anything and da-da-da-da. I'm like, you know what? You don't know anything because you don't know what it's like to actually go out and work in that environment. So shut your mouth and don't criticize. Okay, so a focus history, very important. We're going to obtain this either from the patient, so a primary source, if we're able to do that, a family member, which is a secondary source or witnesses, or then a pre-hospital provider, which would be a tertiary source of history information. And they're going to be able to hopefully provide us some really important information regarding the actual circumstances of the injury. For example, was it a single vehicle crash? Think about that. Think about velocity. Think about if you're going 40 miles an hour and you're involved in a head-on collision. No, it's not just a 40 mile per hour collision. How fast was the car that hit you going? Because if they're going 40 miles per hour as well, then what you've really sustained is an 80 mile per hour injury. What's the fall? Was it from what height? Do we know what height? Were there environmental exposures or smoke inhalation or the possibility of that? Ingestion of intoxicants, pre-existing medical conditions, things like diabetes, depression, which might put them at risk for suicide, for example, cardiac disease, for sudden cardiac death, or other problems that we know are associated risk factors with cardiac disease, for example, stroke, pregnancy, and then what about their medication use? Things like steroids, or that should be beta blockers, I apologize, that may suggest certain patterns of injury or the physiologic response to injury. Those things are all going to be incredibly important things that we hopefully will be able to gather from our historians. Specific injuries that should be immediately identified obviously are going to be your ABCs. So looking at your airway obstruction. Is there a tension pneumothorax? So we need to look very closely at the trach. Is the trach shifted to the right or to the left? Remembering that if it's shifted to the right, then that means the pneumothorax is tension forming on the left. Okay, it's the opposite or contralateral of where you're seeing the tugging. Massive internal external hemorrhaging, so rip the clothes off quickly with scissors, look at the skin, look to see whether or not there is bruising, large areas of ecchymosis, look for the respiratory pattern. Is there a flail chest? In other words, is the patient having paradoxical respiration? So when they breathe in, right, instead of the chest expanding, it actually deflates, and vice versa. And then cardiac tamponade. Look at the jugular venous pattern. Is it distended? Do you see gross jugular venous distension? Well, that could be a sign of impending cardiac tamponade, which could be significantly life-threatening. So we think about A, B's, and C's, so airway, breathing, circulation, and then we also assess D, which is disability, assessing the Glasgow Coma Scale and the neurostatus of our patients, and then E, we also add on for exposure. Disrobe the patient, fully examine the patient, and maintain an inline neck stabilization during the entire process if you suspect a C-spine injury. That's going to be unbelievably important. I'll tell you a funny quick story. When I worked in the emergency room, had this patient one time come in. It was a trauma patient, and I remember I was helping the nurses disrobe her. It was a female patient, and the patient had a bra on, and look, I don't know anything about taking bras off of women, so I took my scissors and I cut the bra off so we could get the bra off. And I remember my good friend Tiffany, so funny, so sweet, she looked at me and she says, "Why did you cut the bra off? Why didn't you just unsnap it?" And I said, "Tiffany, I don't know how to do that. Like, I have no idea how to take this woman's bra off." So it was a really expensive Victoria's Secret bra, so she was kind of like offended, I think, that I had cut this woman's bra off. But so sorry, you got the nurse that doesn't know anything about women's bras. So anyway, I'll never forget that. Tiffany's gone on. She was a paramedic at the time I worked with her. Now she's an amazing nurse, flight trauma nurse, amazing woman that I keep in contact with. So ABCDE, remember that. Your secondary survey is your head-to-toe exam for rapid identification and control of injuries and instability. Determine airway patency. We're going to inspect for foreign bodies. Put your ear down to the airway. Listen for stridor, for example. Look for maxillofacial fractures that may result in an airway obstruction. And you have to remember that you want to intubate quickly when the patient needs it. But you also, if there's an airway obstruction, don't want to throw a tube down and risk the possibility of lodging whatever the foreign body is down into the lungs even further. I've actually had this recently happen where we had a patient in the nursing home that I see, a pulmonary patient who what she aspirated a huge, I think it was calcium tablet. We Nobody knew. Everybody was freaking out. They had to code this woman. Brought her into the hospital, intubated her, brought her into the ICU. Thought she was going to die, and I think on day 2 of the ICU stay, the pulmonologist that I work with went in and did a bronchoscopy on her, found the foreign object, removed it through the bronchoscopy, and the patient stabilized. But it was a nightmare that nobody knew, that that's what had happened. People thought she just went into respiratory failure. And I was actually in, where was I? I was speaking at a conference in DC. I'm getting text messages on my phone from the nurse practitioner that's the Gero nurse practitioner at the facility saying, "Oh my God, Chris, one of your patients is in the ICU." And here I am at dinner with many of my colleagues, many of whom have probably taught you in classes, and I'm calling the hospital, calling the nursing home, trying to find out what's going on. And luckily, we did stabilize her, and I see her every week, and she is completely 100% back to her baseline, which is a miracle. I cannot believe that she did not die or end up with significant neurologic problems. So performance of the jaw thrust maneuver simultaneously in line with stabilization of the head and neck, followed by the insertion of that means, by the way, you need a partner to help you, followed by the insertion of an oral or nasal airway should be part of the first response. So if the patient's not making an adequate respiratory effort and they're struggling, we don't screw around, we tube them right away. In a trauma situation, the last thing you want to do is wait and the patient end up buying a tube way too late. Obviously, there are some limits to that. If the patient has a basilar skull fracture, then no nasal airway is going to be conducted. This particular schematic that you see here is of the basilar skull fracture. I found this online. I stole it. Okay, so I want to talk about a couple of hallmark signs that you see when a patient comes in with a basilar skull fracture. And the thing to remember is, hang on, I have to cough. Okay, sorry about that. The thing you have to remember about basilar skull fractures is that they can either be anterior or they can be posterior. And one of the early autopsy cases I ever worked was a patient who fell from a forklift during the construction of the Cirque du Olay circus tent down at Disney, which is now closed. They don't have that show anymore down there. But this guy fell off of the forklift, young guy, like 20, 21 years old, very sad. But I remember when they laid him on the table for autopsy, there were immediately two things I noticed. And let me see, this picture probably does a better job. Okay, so you see this here, all right? That is called otorrhea, so discharge from the ear, right? A bloody discharge. That's actually CSF. Usually it's more of a pinkish color. And then you can kind of see it here, this ecchymotic discoloration of the mastoid process. And that is hallmark of a basilar skull fracture, okay? So those two, oops, what happened? Sorry. So those two physical exam findings largely suggestive of basilar skull fracture. And I remember we're doing this autopsy on this guy, and the pathologist said to me, "Well, what do you think is the cause of death here?" And I said, "Well, from the looks of the otorrhea in combination with the battle signs back here, it looks like a posterior basilar skull fracture." He said, "Yeah, I think you're right." And then we ended up gutting this kid from stem to stern, and right from the get-go, we knew what it was. And I kept thinking to myself, geez, why did we just waste all those resources really mutilating? If you've never seen an autopsy, it is brutal. But in the end, you make an incision back here, and they cut all the way from this, basically the sternocleido on this side all the way to the SCM on the other side, and then they just basically peel all this back. It's like a mask. It is shocking to see. It's like I don't know if you've ever seen Texas. I love Texas Chainsaw Massacre. I'm crazy, sick, perverted horror movie fan, but I love Texas, especially the remake in 2003. I'm a huge Texas Chainsaw fan, and really, like when I saw the movie, I'm like, damn, they got it right, because this is exactly what it looks like. They peel the face off, and sure enough, we saw this large fracture, and it was comminuted. I remember that, and it was just all the way across the back of the skull. And That was the cause of death, was posterior basilar skull fracture. And that is in contrast to an anterior basilar skull fracture where you see what we call raccoon eyes. Okay, so maybe here you can see a little bit better. I've got an actual picture when we discuss this further. But raccoon eyes, which are these black eyes, and then you see what we call rhinorrhea, which is this disgusting, it's bloody here, but it's usually more of a pinkish CSF discharge that occurs anteriorly. Patients usually don't have both anterior and posterior basilar skull fractures, but they can, all right? So keep that in mind. And we'll talk more about skull fractures and treatment of that when we get to that part of the actual unit. Okay, whenever possible, use of a two-person spinal stabilization technique is suggested, so one provider will devote undivided attention to the C-spine. So they're going to actually maintain that inline immobilization and prevent excessive movement of the C-spine while the other manages the airway. So even if you're tubing a patient, like I said, this is a two-person sport where one person actually stabilizes the C-spine with their hands, really stabilizes the neck so that there's no vertebral damage that's iatrogenic, and that we don't contribute to what's going on. So if the Glasgow Coma Scale is a score of 3 to 8, you must intubate. Remember that. GCS 3 to 8, you must intubate. I should be a cheerleader, right? If anatomy or severe maxillofacial injury precludes endotracheal intubation, then you're going to have to crike the patient. And I'll show you, I think I've got some pretty gruesome pictures of facial injuries where you're going to be able to see some of this. Rapid sequence intubation is almost universally going to be required in trauma patients, unfortunately. That's as a consequence of their suffering, unfortunately, because they're in so much pain and they're under so much distress that oftentimes they'll buck the vent and buck the further trauma that they're experiencing of having a tube shoved down their throat. So usually these people have to be rapid sequenced. Clearance of the C-spine from serious injury involving careful assessment and with or without radiologic imaging. Usually with radiologic imaging if you strongly suspect injury. We'll talk more about that. So many centers will apply this nexus criteria and then ask the patient to move the C-spine about 45 degrees in each direction. These are the Canadian guidelines. So if they have failure of one of the following things, then they've got to do imaging. All right, we'll talk about imaging. I remember on my acute care board exam, I had a ton of C-spine images that they expected me to know. So we're going to hopefully be able to go into some detail so that if you get those on your board exam, you'll know how to answer them. So one of these things, if they fail it, they buy imaging. So either no posterior midline C-spine tenderness, no intoxication, alert mental status, no focal deficits, no painful distracting injuries. All right. If they have a positive any of these, then we're going to image them. All right. And let's just get this out on the open right now. When we talk about focal neurodeficits, all right, the way you are going to assess for focal neurodeficits is going to be, sorry for my typo there, is going to be threefold, okay? Obviously, mental status is going to be important. If the patient is alert, oriented times 4, all right, person, place, time, and event, then that is going to be one factor, right? So they're not necessarily focal. They're not necessarily having any focal deficits if their mental status is intact. Then from there, you're going to assess your 12 cranial nerves, okay? Obviously, cranial nerve number 1, your olfactory nerve, that one is not going to be assessed, okay? You just don't assess that. But you might use a handheld Snellen chart to assess cranial nerve number 2. Remember that cranial nerves 3, 4, and 6 are tested together. So you're going to shine your light into the pupils, look for a fast, brisk response, and then you're going to follow the cardinal eye gazes. Is the patient able to track your movements with your pen light? All right. And then remember that cranial nerves 5 and 7 are tested together, that those are the patient's going to be able to smile and puff their cheeks real heavily, and you're going to see if they're able to do that, or is there air escaping from the cheeks asymmetrically. Obviously, that's going to be an issue. Cranial nerve number 8 is going to be your acoustic nerve. You're going to make sure that they can hear okay, that they're not dizzy, they have no, for example, vertigo or any of those types of symptoms. And then cranial nerves 9 and 10 are going to be assessed together. You're going to ask the patient to open their mouth. Now, obviously, if they've got facial trauma or something that would be contraindicated here, you would not want to do this. But cranial nerves 9 and 10 are your gag reflex, and you want to look for an open and symmetric mouth with a normal, quote unquote, soft palate connected to the hard palate. And when they gag, that uvula is midline, and everything that you see inside that oral cavity is in fact symmetric, okay? And then your spinal accessory nerve number 11, you're going to put your hands on the patient's shoulder, ask them to shrug. You should feel equal and symmetric 5 out of 5 muscular extremity strength during that exam. And then finally, your 12th cranial nerve is going to be your hypoglossal nerve, and for that they want to stick their tongue out. You want to make sure that they're able to shift their tongue back and forth in their mouth strongly, symmetrically, no issues doing that. Raise the tongue to the roof of their mouth. Make sure they've got that full symmetric ability to move their tongue. So mental status, right? We said that was the first part of looking for focal deficits. The second part was your 12 cranial nerves. We just went through those. Those are off. That was off the top of my head. But I've been doing this for quite some time. You may not know off the top of your head the 12 cranial nerves, but you need to. They're all over your board exam, and as an acute care NP, this has got to become first-hand knowledge for you. You cannot whatsoever not know how to assess the 12 cranial nerves. And then the third part of this, looking for focal deficits, is assessment of muscular strength and, well, we can throw in their range of motion too, although if you have a trauma, obviously that's going to affect it. But really muscle strength of the patient's upper extremities and lower extremities, right? So squeeze your fingers, apply opposing pressures, both flexion and extension to the arms and the hands and the feet and the legs. Check abduction strength, adduction strength. All of those things are going to indicate focal deficits. If you ever perform a neurologic exam, and by the way, that is pretty much it for your neuro exam. You don't need to know all these specialized monofilament tests and all that stuff. If you can get through what I just said, then the chances are, if the patient has any abnormal finding whatsoever, they've bought themselves a CT scan. In this case, they've bought themselves a CT scan of the C-spine as well. Okay, so unbelievably important that you know how to correctly assess the neurologic system, and I just went through that with you, so hopefully you'll now remember that. Obviously, if they're obtunded, you have to assume that there is in fact a C-spine injury, and this is important. CT of the C-spine is the image of choice. X-rays miss up to 15% of injuries, so you really need to remember that CT scanning is going to be ideal. If you get that on your board exam, don't pick the X-ray, pick the CT scan. Obviously, if they're greater than 65, a high mechanism of injury, if they're getting other scans of the head, chest, or abdomen, then they've bought a CT scan of the C-spine as well. And for those who you might have inadequate visualization of the lower C-spine and upper thoracic spine, someone that's morbidly obese or someone that's got significant, for example, neck edema, or Ludwig's angina, something like that, you're going to have to get the CT scan of those folks as well. You want the film to go all the way down to T3 because you want to pick up occult pneumothoraces. You don't want to miss those. For breathing, assess for pneumothorax. Obviously, needle thoracostomy. For tension pneumothorax, remember that that is inserted at the midclavicular line, right? Usually it's at the second intercostal space, midclavicular line. If they have a hemothorax or a pneumothorax, they're going to need a large bore chest tube, okay? Especially hemopneumothorax, because remember that the smaller the chest tube, the more likely it is to get clogged. And we know that blood, if you've ever seen a hemothorax before, I've only seen one a couple of times, but probably the most brutal one I ever saw. We had a patient that came in after an MVC, and we had to put in a chest tube on her, and I remember assisting the physician, and when he cut the chest to put in the tube, it was like coffee poured out of her chest, and literally it looked like coffee grounds from all the blood clot. So what am I getting at here? The larger bore chest tube is going to be essential, because if you put in a smaller one, it's going to get clogged, and then we're going to have a real problem on our hands with tension and everything else. So 36 French in size. Sucking chest wound, we're going to apply an occlusive dressing. I'll show you that, I think, a little bit later. For asymmetric or absent breath sounds, if the patient's intubated, then we're going to have to withdraw the endotracheal tube, because the odds are you've gone in the right mainstem bronchus, or even worse, you may have gone in the gut. I have to say, you don't want me to intubate you if you ever come in, because unfortunately the handful of times I've intubated, I hate to tell you this because it's embarrassing, but I've only gotten it once. All the other times I've intubated, I've hit the stomach, so I am not a good intubator. So I just don't do that. I let somebody else do that. Respiratory therapy can do that. Unless you guys are probably better than me, so if we ever work together, I'll hand you the blade, and I'll say, here dude, go ahead. Okay, if there's no breath sounds heard, then a massive hemothorax or vascular injury is going to be your suspect, and then you're going to need your thoracostomy, or what we call VATS, video-assisted thoracic surgery, to identify the source of the bleeding. So you may even have in the emergency department, that's going on, or even a bronch going on right then and there, to determine, is this something that we can zap through the bronch, or is this something that we're going to need to go and do an open thoracotomy on. Any hypotensive trauma patient is at risk for the development of hemorrhagic stroke, and it is a common cause of post-injury death. So remember that. Hemorrhage and shock are on a continuum, and you do have some patients that can compensate when they have significant blood loss. So some things to remember: hemorrhage of up to 30% of total blood volume may be associated with only mild tachycardia. So really, you're not going to even see this shocky state occur in some people until later, and then a decrease in pulse pressure, but may quickly progress to profound hypoperfusion and decompensated shock if not recognized early. All right, so even though we may not see it in the vital signs just yet, the patient is in fact experiencing tissue hypoxia and lack of perfusion. So apply direct pressure or a compression bandage to control active external bleeding. We want to establish 2 large bore IV lines, which are going to be preferably 18 gauge or larger. If we can't do that, then we've got to go for our either subclavian or femoral line. Okay, and femoral line is really not going to be ideal because that's got the largest chance of infection. So again, avoid that area. Obtain blood samples or specimens for lab, and we obviously, in patients that are losing lots of blood, you need to get your blood type and screen. Okay, you got to do that. Hypotensive patients without an obvious indication for surgery should be reassessed after rapid infusion of 2 liters of a crystalloid solution. And really, lactated ringers is going to be your choice. All right, used to be that we went with normal saline for fluid resuscitation. That was like our first and foremost, but we've learned now that there is a risk with rapid transfusion and large amounts of saline that the patient can develop what we call hyperchloremic acidosis, and we want to avoid that. So instead, you can choose lactated lactated ringers, which is going to be less risk for that. Remember, if there's no marked improvement, then you're going to have to transfuse. And remember that O negative is the blood of choice for the universal donor. Remember this: O is the HO. The O blood type can donate to anyone as long as it's negative. So we can review ABO real quick. Just remember that, well, here, I'll just throw it out real quick. If patient's A positive, they can take A positive, A negative, or they can take O positive or O negative because they have the positive Rh antigen there. So O will actually be okay if it's positive in this case. If the patient is AB positive, okay, that means that they are the universal recipient. They can receive A negative, A positive, B negative or B positive, AB negative or AB positive, O positive, and O negative. All right? If the patient is O, then this is an important concept for them. They can only get O. So if they're O positive, they get O positive blood, or O negative blood. If they're O negative, they only get O negative. And I think B is the only one I left off. So if the patient's B negative, they only get B negative or O negative blood. And if the patient's B positive, they can get B negative, B positive, O positive, and O negative. Okay, I hope I got that right because, again, that was all from the top of my head. But you got to know ABOs. You got to know that, quickly recognize blood type. Do you know your blood type? Hopefully you do. I know I am A positive. So if I ever need blood, if you are A positive, A negative, O positive, or O negative, get your butt to the hospital and donate some blood to me, baby. I need it. All right. The fast is pretty cool. I really want to learn how to do the fast. I'm not a huge fan of ultrasound right now because I'm just so inept at it. But the fast exam is amazingly cool. It is used to rapidly assess the patient who has experienced trauma using ultrasound. It can help identify intraperitoneal hemorrhage or even pericardial tamponade from a large, for example, pericardial effusion. Saline, or like I mentioned, lactated ringers is going to be your fluid of choice, and we talked about the advantage of lactated ringers. Transfusion, administration of platelets, and massive transfusion protocol in a 1:1:1 ratio with packed red cells and fresh frozen plasma is recommended. And in your critical care pharmacology course, Dr. Guido Sands went over all the information you need to know about transfusion and blood products, but this is, and we know that we don't give them very frequently. In the acute care setting, we give them way more often than we need to, but in a trauma patient, it's a little bit different. We're really trying to work against the clock. Both acidosis and hypothermia contribute to coagulopathy, so we got to fix that very quickly. Once airway, breathing, and circulation have all been addressed and stabilized, then an abbreviated neuro exam can be done. So we can look at level of consciousness, pupillary size, reactivity, motor function, looking at Glasgow Coma Scale, acu-checking, looking for a urine tox screen as well. Patients with a persistent GCS less than 8 generally have a graver prognosis, and they need a definitive airway because those guys are going to lose their airway, they're going to aspirate or asphyxiate, and we don't want that to happen. Intubated patients should undergo continuous capnography, and we want to make sure that our CO2 levels are kept between 30 and 35. Palpate the spinous process of the thoracic and lumbar spine for tenderness or deformity, and carefully log roll the patient back to a neutral position. I used to work with an ER physician that believed in the rectal exam because she said you really want to make sure that there's no internal bleed, and if the patient is bleeding, oftentimes you'll pick that up with a rectal vault exam, but there is some controversy about this, and it is useful to identify gross rectal bleeding or loss of rectal tone, but probably not so much in terms of an upper bleed like we once thought. So if you're looking for rectal tone that could be lost from a spinal cord injury, for example, yeah, that might be a good thing to do. do. Or if you're looking for a gross rectal bleed, yeah, might be a good thing to do. But keep in mind that rectal pressure like that is going to increase ICP. And if the patient's got a brain injury, the last thing you want to do is be poking their butt and causing increased ICP to the point where they could herniate. Same with a Foley catheter, by the way. Used to be anybody came in with they were obtunded or anything, we would immediately drop a Foley, drop a rectal tube, all that stuff. We don't do that anymore. Now we know better, but when I was a bedside nurse, eons ago, we did that. Examine the perineum for bruising, lacerations, or bleeding. For example, you might see this in a really bad pelvic fracture, which bleed terribly, and you might see a large, boggy perineum with significant hematoma. Cover the patient with warm blankets if they're hypothermic to prevent heat loss. Head and spinal trauma, CT scan them immediately. Don't defer unless you need to address other injuries. So obviously if you need to address the airway, that's going to be important, or if you're going to have to stop bleeding or perform a tamponade procedure, all that's going to be important, but you really want to get them into CT scan as quick as possible. Tension open hemothoraxes or pneumothoraxes. A tube thoracostomy should be performed in a timely manner. If the patient has absent breath sounds, penetrating trauma, chest wall ecchymosis associated with tympany, dullness to percussion, respiratory distress, hypoxia, or tachycardia, they are going to need that chest tube. Penetrating abdominal injuries, abdominal tenderness or distension on palpation coupled with hypotension indicate the emergent need for surgery. So they got to get them into the operating room suite, get them out of the ED. No fast in a gunshot wound, and don't do things like I mentioned, like NGs, Foleys, or even an IV. If the patient is on their way to the OR, let them do that in the OR. You've got to prioritize. You remember that time is tissue, and the longer you wait putting in a Foley catheter or putting an NG tube, for example, the less chance the patient has to survive. So time is tissue. Time is of the essence when we're talking about trauma. Impaled objects. Here's a couple pretty pictures for you. Objects that are deeply impaled in the chest and abdomen should be left in place, and the patient rapidly transported to the OR for surgical removal under direct visualization. And we do that because sometimes if you were to pull out the penetrating object yourself, or if emergency workers were to do that, then the patient could bleed. If it's, for example, some of these injuries can actually tamponade off a major vessel, and if you pull the item out, you'll actually either relacerate the vessel or you'll actually remove the tamponade and the patient will start hemorrhaging. So leave them in place. Let me get my little pointer here. Okay, the reason why I like this picture so much is you get a really great visualization. I don't know if this is real or not. This might just be a simulation, but I like this a lot because you can see how to stabilize a penetrating injury. And this one, they probably should have done this and they really didn't. But you can see that there's a gauze here and a gauze there, and then it's circumferentially placed so that that penetrating object doesn't break off, come loose, cause problems. The strongest recommendation for performing ED thoracotomy can be made for victims for penetrating traumas to the chest with witnessed signs of life during transport or in the ED, and at least some cardiac activity upon arrival. So those are important concepts. Secondary survey is reassessment. So reassessment of blood pressure, pulse rate, vital signs, central venous pressure should all continue during that period. We're going to control hemorrhaging with either staples or Rainey clips. We're going to inspect the tympanic membrane for hemotympanum and repeat the pupil exam. Inspect the urinary meatus, scrotum, and perineum for blood, hematomas, and lacs. Perform a rectal exam for sphincter tone, gross blood, and prostatic bogginess or even displacement. And if meatal blood is present or the prostate is displaced, suggesting a urethral injury, then we're going to perform a retrograde urethography before we put a Foley catheter down. We would never want to, insert, for let's say, for example, the urethra was actually fractured for some reason, and you put in a Foley and it actually went through. Can you imagine? You damage the penile tissue and everything else, or things like this can, not so much for a female because the urethra for a female is just anatomically different, but still. For females, though, if there's a vag bleed, you want to perform a manual and speculum exam and see if there's a possible vag lac or maybe even a pelvic fracture. Evaluate the extremities for fracture and soft tissue injury with attention to your peripheral pulses. And of course, guys, like I'm going to mention throughout here too, documentation of these things is vital. If the patient had 2+ pulses or 1+ pulses when he or she came in, then you better document that. I've been working on a lot of malpractice cases lately, and I'm seeing really bad examples of documentation that's not very objective. Good pulses, for example. What is a good pulse? That's very subjective. No, pulses are graded from 0 to 2. Actually, they're graded from 0 to 4, but normal in this case for trauma would be 0, nothing, 1, thready, and 2, normal. Right? 3 is going to be 3 and 4 are going to be your bounding, more forceful pulses. So perform a more thorough neurologic exam, checking your motor and sensory function, like I mentioned before. The most frequently missed conditions are orthopedic, so you're going to have to pay real careful attention to your orthopedic extremity injuries, especially in those with multi-system traumas. Yes, we think airway, breathing, circulation, we think heart, we think lungs, we think brain, but miss a latent or hidden femoral fracture that develops into a compartmental syndrome and the patient loses their leg, or miss that type of accident and the patient throw a fat embolism, and we're in a real mess. So again, we can't just ignore things that we think are less important, even though they somewhat are. Chest and pelvic radiography outside the peritoneal cavity can accommodate volumes of hemorrhage blood sufficient to produce hypotension and shock. So don't just look at chest and pelvic radiographs. You need to look, or I should say, don't just look at the peritoneal cavity, look at regions outside of that area as well. If your patient with a gunshot wound to the torso, a chest radiography is required with or without abdominal films, depending on the site of entry. I did say entry, not injury, but entry, and exit for that matter. If the patient's obtunded or they have a multi-system trauma, then we're going to have to image the entire spine and probably get a CT scan of the head as well. Routine lab studies are going to include things like blood type and screen, a hemoglobin level, urine dipstick testing for blood and alcohol levels. In women of childbearing age, we're going to do a pregnancy test, checking capillary blood glucose level, very, very important in any altered mental status. Patient comes in with an AMS, the very first thing you do is check their oxygen status, their oxygenation. The second thing you do within seconds after that is get an AccuCheck. Obviously, in patients with a history of diabetes, that's going to be more appropriate, but really it's for everyone. In patients who are older than 55, consider obtaining an ECG and measuring levels of cardiac markers like troponin for ischemia. Okay, like I mentioned, we were going to discuss some specific geriatric trauma. Let's go into that. So the elderly are more susceptible to serious injury from low injury mechanisms. You might, for example, like my mother was at my house a few years ago, and God bless her, I get so sad when I tell the story because she was helping me empty my dishwasher out, didn't see the door down for the dishwasher, tripped over it, fell, and broke her hip. It was a nightmare on every level that you could possibly imagine. My sweet mother, my mom's a very sweet woman, and it breaks my heart to think that that happened to her. You or I fall on our hip, chances are we're not going to break it, right? We're young, we go to the gym, hopefully we exercise, we do the things that we need to do. But my mom, severe COPD, she's on steroids 90% of the time, all those things cause pathologic fracture. So just a low injury fall, where it's not even a fall from a elevated platform or an elevated space, caused her to break her hip. They're less able to compensate from stress of injury, and they're more likely to suffer complications. One of the first things I did when my mom came out of surgery for her hip is I said to the nurse, let's get an incentive spirometer right away because I don't want my mom to develop pneumonia. Already with compromised lungs, she doesn't need that. Made sure she was on breathing treatments, anti-epileptic maneuvers, all those things that we know are very vital. This is my mom we're talking about, and oh God, I remember she came out of surgery and she was in so much pain. Oh, it breaks my heart. I remember holding her hand and she couldn't really talk because of the anesthetic, and she would just look at me and say, pain, pain, pain. Oh. Anyway, terrible. Awful memories. Okay, so although the elderly are less likely to be involved in trauma as compared with other groups, they are more likely to have fatal incidences when they are involved in them. Part of the difficulty in describing the elderly population derives from discrepancies that can occur between chronologic age and physiologic age. A patient might say, well, I'm 60, but they look like they're 100. We've all seen this in the hospital. So chronologic age is the number of years the patients live, but the physiologic age, we consider things like pre-existing conditions and the functional capacity and the organ function and all those things that come into play. So somebody may look like they're 80 and tell you that they're only 60, and we see that all the time. And usually I have one physician that I work with that's really good about documenting that. He'll just write advanced age. I'm not sure if that's the actual diagnosis for that. I don't know what would be, but it's certainly something that does happen. Falls are going to be your most common cause of injury in patients greater than 65. My mom currently is 72, and that was, I think, 2 years ago that she broke her hip, so she was 70. There are age-related changes in postural stability, balance, motor strength, coordination, and reaction time that makes the elderly more prone to tripping and falling. They're more likely to have adverse effects from drugs and alcohol. Motor vehicle collisions rank as the second leading mechanism of injury, and they're most common cause for fatal incidents when persons are through the age of 80. Pedestrian motor vehicle collisions, one of the also most lethal mechanisms of injury, about a 53% case fatality rate. Elderly also have a higher fatality rate than younger adults with the extensive burns and even non-major burns. Less than 20% of BSA, for example, can be very significant for elderly persons, but not so much for younger people. So your history of pre-existing medical conditions is going to be vital to assess medication used to treat that may have precipitated the traumatic event, affected the patient's ability to compensate from stress of injury, confusion of interpretation of physiologic response and degree of physiologic distress, and these things can complicate resuscitation. Remember that dysrhythmias can precipitate a ground level fall. Patient ends up getting, for example, significant AFib, and all of a sudden they feel faint and they fall. Cardiac agents like beta blockers can confuse interpretation of vital signs. So a patient might be experiencing shock, for example, and they come in and they have a normal heart rate because they're on beta blockers. Conditions such as COPD may limit the patient's ability to compensate for lung or chest injury, and anticoagulants can increase the risk for ICP. Increased ICP from bleeding, and even after a minor head trauma. I remember I had a patient one time I treated that had a simple fall in the nursing home. It wasn't anything dramatic, and she had an INR of 19 when she came into the ED and a massive subdural that was forming in her brain. So, again, on anticoagulants, you're at high risk for these things. Conditions such as congestive heart failure can significantly alter response to resuscitation strategies as well. Your physical exam, the myocardium becomes less sensitive to endogenous and exogenous catecholamines and decreased pumping effectiveness. So you got to keep that in mind. And there's also conduction defects that can be exacerbated by the stress of illness or trauma. So the normal tachycardic response, like I mentioned, may be blunted, and medications such as beta blockers may actually be the cause of that. Blood pressure can also be misleading because the prevalence of pre-existing hypertension is up as large as 70% in this group. So vital sign trends, I should say, may be more useful than a single set of vital signs, and there should be carefully tracked vital signs in the ED or the ICU wherever we're treating the patient. Looking at trends is important, more so than just looking at your one set of vitals. Respiratory rate less than 10 and a systolic less than 90 indicates a very high rate of mortality, all the way up to 100%. So again, pay close attention to those vital sign trends when the patient presents. Airway management can be more difficult in this group because of dentures that can actually occlude the airway, cervical arthritis, which adds danger to extending the neck, and then your TMJ, which may actually hinder the patient's ability to open his or her mouth. Age-related reductions in vital capacity, functional residual capacity, and forced expiratory volume can limit patients' ability to compensate for chest injuries. Remember that the vast majority of us, as we age, will develop obstructive pulmonary disease, even if we're not smokers. Obviously, if we're smokers, then it's going to be accelerated and exaggerated at much higher rates. But even if we're not smokers, as we age, our vital capacity and the functional capacity of our lungs really begins to reduce because basically we lose the elasticity and recoil function of the pulmonary system, and as a consequence of that, unfortunately, we end up getting these problems. The elderly may also have blunted response to hypoxia and hypercarbia, as well as to acidosis, which can then delay the onset of clinical signs. Because of their more osteoporotic and brittle chest wall, they're more susceptible to rib and sternal fractures from blunt trauma with attendant splinting and hypoventilation. So what does that lead to? Yes, that's right, that leads to your pneumonia. Elderly trauma patients often have impaired chronotropic response to hypovolemia. Chronic hypertension actually may mask hypotension. So again, things that, are physiologically different in our elderly folks that we don't see in our younger folks. Seemingly stable geriatric trauma patients can deteriorate fast and without warning because of low physiologic reserve. And here are some more examples of things that you might see in your elderly patient which will in fact impact their resiliency after experiencing a stroke. So take a look at this little schematic here. I thought that was pretty good. Head injury, mortality for patients greater than 55 who have a severe brain injury with a Glasgow score less than 8, 80%. You compare that to just 38% in your younger folks, and you see how much of a serious issue this is. Almost 9% of geriatric patients are taking Coumadin, and in the anticoagulated patients with blunt head injury who are experiencing no or minimal symptoms, the rate of intracranial hemorrhage can be as high as 14%. That's a lot. All right. Now, Coumadin is kind of falling by the wayside, so patients might be taking Xarelto or Eliquis or some of the newer anticoag drugs, but remember, guys, that doesn't matter. If our patients are on those drugs, they're at increased risk of bleeding, and these are the folks we're talking about. When evaluating the patient's mental status, it would be a grave error to assume alterations in mental status are due solely to an underlying dementia or senility. It could be, in fact, the injury, and you should presume it is the injury. Elderly persons are less prone to develop epidural hematomas than the general population. That's because they have more dense fibrous bonds between the dura mater and the inner table of the skull. There is, however, a higher incidence of subdural hematomas in the elderly population. All right, so subdural, yes. Epidural, not so much. Diagnoses of intracranial bleeding may be delayed because of brain atrophy, and you don't obviously see some of that on an imaging study, and you have to actually wait until blood accumulates, and then you start to see the clinical signs, which are usually related to increased ICP. More liberal indications for CT scanning of the head are therefore justified in your elderly folks. You don't want to wait. C-spine injuries. Because patients in this population are greater than age 65, they all get a CT C-spine. Odontoid fractures are particularly common in your gero folks, about 20% of all gero C-spine fractures compared to just 5% in your non-geros. And in order to assess an odontoid fracture, you need to get what's called a transodontoid view. And I'm sure I've got some images of that when we get there, but basically those images are taken through the mouth. So the patient has to actually open his or her mouth to get those films. With hyperextension injuries, Elderly patients may develop central cord syndrome as well, and we'll talk more about spinal cord injury when we get to that particular area of the unit. So remember that extension of the neck means the base of the skull is being moved back towards the back, and flexion would be the chin to the chest. Okay, so I know that's very basic, but oftentimes we have to think about these terms of what's flexion, what's extension, and remind yourself. Okay. Chest traumas, if they're in this group, the risk of pneumonia increases by 27%, and the mortality increases by 19% for each rib fractured. So we're all the way up to, for example, 60% almost if a patient has just 3 rib fractures. More severe thoracic injuries and hemopneumothoraces, pulmonary contusions, flail chest, and cardiac contusions can quickly lead to decompensation in elderly folks whose baseline oxygenation status may already be diminished. So for example, someone with really bad COPD, you're already going to have diminished capacity, and you're going to end up seeing these issues. Abdominal trauma, even with an initially benign physical exam, emergency acute care NP should have a high index of suspicion for intra-abdominal injuries. If you've got a fractured pelvis or a lower rib cage fracture, these bony structures can become sharp when they become fractured and can obviously become internally penetrating injuries. So you need to be on the lookout for that. Some patients can be volume depleted because of their meds like diuretics, and hypovolemia coupled with contrast administration can then cause significant renal pathology. For unstable patients, and especially those with multiple scars on the abdominal wall from previous procedures, a focused assessment with sonography for trauma exam is ideal. Okay, so really looking at a fast test, fast exam, very important for these folks. Some other injuries: elderly trauma patients are unique in that they're susceptible to pelvic fractures from low energy traumas. We talked about that. I gave you my mom as an example for that, although she didn't fracture her pelvis, thank God. In addition, they have higher rates of hemorrhage for given severity of fracture, especially if they're on anticoags. Hip fracture is the single most common diagnosis leading to hospitalization in all age groups in the U.S. They typically occur in 4 areas: the intertrochanteric, transcervical, subcapital, and subtrochanteric regions. Intertrochanteric fractures are the most common, followed by transcervical fractures, which is what my mom actually had. Hers was through the cervical, through the neck of the femur, which is what we call transcervical. Bleeding from closed pelvic and long bone fractures can cause hypovolemia in our elderly patients. And the one thing that's not here that I should have included is the possibility of fat emboli. So if a patient ever comes in with a suspected long bone fracture, the first thing you do is you put them on oxygen, because oxygen reduces the surface tension of the fat globule, makes it less likely to lodge into the pulmonary tree. Falls on the outstretched hand increase the risk of Colles fractures, and after the diagnosis is confirmed by radiographs, Colles fractures can usually be treated with closed reduction and immobilization. So years ago, I was inducted as a fellow into the American Academy of Nurse Practitioners, or now we call it the American Association, but the American Academy is what it traditionally was known as. And I have to be honest with you, it is a very rare feat to get inducted as a fellow into any academy in nursing, and the Nurse Practitioner Academy is one of the more difficult ones to get inducted into. So it was a hell of an honor for me to get selected for that. But I'm not going to be, I'm not going to be reserved here. I'll be honest. I'm a hard worker. I've worked very hard in my career to get where I'm at, and I feel like I legitimately have made some serious, groundbreaking areas of scholarship in the world of LGBT health in nursing. So I'll take credit for that. But unfortunately, when I did get inducted, one of my dear friends that I used to teach with, Dr. Josie Weiss, was the director of our primary care in PTRACs at UCF for a long time. She we were on the way to the ceremony where I was going to get inducted, and she was going to be the person to walk me up on the stage and do all that. And wouldn't you know it, guys, as we're walking to the convention center where the ceremony was to be held, Josie tripped and fell, and this outstretched hand to stop herself from falling, she fractured her radius, fractured her wrist. It was awful. I mean, it hurt. You lift. I watched her fall. I looked back. Oh my God. Immediately, this large hematoma started to form on her wrist, and I thought, "Oh shit, Josie, you've broke your wrist." And of course, instinctively, you say, "Are you okay?" And she looked at me and she said, "I broke my wrist." And I said, "Oh, honey, I know you did." And we called 911. This was in San Antonio, Texas. We called 911. They were there within 30 seconds. Her husband, who is an angel, he's a minister and he's also a neurologist, he was there with her. I said, "Josie, I'll skip the ceremony. I'll stay with you." She said, "Of course not. You go. This is the biggest moment of your life." And she was right. And so I went on to the ceremony. Paramedics brought her to the hospital, and she ended up getting surgical repair of her hand. Just absolutely broke my heart. I mean, it was just... it was awful. So you confirm those by radiographs. Colles fractures can usually be treated with a closed reduction and immobilization. And I remember she had to stay behind in San Antonio for several days. And then when she got back to Orlando, she had to undergo the physical therapy and occupational therapy and all that stuff. So this is what a Colles fracture looks like on a film. You can see the displacement here, pretty good on the lateral view, right? And then in the little schematic here, this is what it looks like. The bone just totally fractures away from the, I think that's, oh gosh, that's not the hamate, that's the hamate. I'm really bad sometimes at remembering these wrist bones. It might be the trapezius. But anyway, you can see where that, the radius just totally fractures from its articulation point. So pretty gruesome, pretty awful, not something that you want to have happen, and unfortunately very common in your elderly, and it does have a significant recovery. Labs are the base deficit and lactate levels provide a good initial measure of shock, and then your serial measurements can guide resuscitation decisions. So looking at the base deficit and your lactate levels, they both correlate with systemic hypoperfusion that may be occult. So like we said before, you may not see it on the vitals, but it's happening. And so those levels then become markers that we can use to correlate with ICU length of stay and even mortality. So a normal or mild base deficit from -3 to -5, they have about a 24% chance of mortality. If it's from 6 to 9, it goes up to 60%, and if it's greater than -10, greater than 80% mortality. So again, pretty serious but reliable marker there is going to be your lactate level and your base deficit. The American College of Surgeons recommends that EMS providers transport trauma patients who are greater than 55 to a designated trauma center. We talked about oxygen saturation and maintaining oxygen saturation, very important. Keep them above 95. Assess your serial arterial blood gases because they can provide some early insight into respiratory function and reserve. And prompt tracheal intubation and use of mechanical ventilation is going to be mandated if the patient has severe injuries, a respiratory rate greater than 40, a PaO2 less than 60, or a PCO2 greater than 50. All right, these are going to buy these elderly folks the tube. All right. Elderly trauma patients may benefit the most from an expeditious transfer to the ICU so that we can really closely monitor their HD status. During the initial resuscitative phase, crystalloids, although the primary option should be administered carefully because these patients have, for example, CHF or any kind of diminished cardiac compliance, they're going to be more susceptible to a volume overload. So that happened because I jumped ahead and read crystalloid. Serial crystalloid fluid boluses starting at about 250 up to 500 cc's can be given. Looking at blood pressure, their respiratory status, their urinary output, making sure we're not overloading them. Strong consideration we're going to have to consider for these guys for red blood cell transfusions, depending on the type of injury and severity of blood loss. Switching to blood transfusion after 1 or 2 liters of crystalloid should also be considered. All right. Despite the multitude of options, there is, as of yet, no true panacea for reversing anticoagulation in patients with intracranial bleeding. Full reversal with fresh frozen plasma may require administration of up to 4 liters of FFP. And then, of course, you give anybody 4 liters of anything, you're going to overload their fluid. Hematoma expansion appears to occur largely with the first several hours of an injury, making sole administration of vitamin K with a very slow onset of action inadequate. And the risks for thrombotic complications need to also be considered. Elderly patients with polytrauma, significant chest wall injuries, abnormal vital signs, or evidence of overt or occult hypoperfusion should be admitted directly to the ICU. And the number of severity of pre-existing medical conditions is an important predictor of mortality, which is independent of chronologic age. So the effect of pre-existing conditions can actually become less important after the patient is of age 65. So in other words, at that point in life, that chronologic age becomes a more powerful predictor of mortality than their actual pre-existing medical conditions. That's pretty significant that the effects of aging can be more powerful than the actual patient's history of problems. Okay, that moves us into the head trauma area, and we're going to be talking about head trauma in adults. Traumatic brain injury is classified based on the clinical assessment of a patient's level of consciousness with little or no regard to the actual underlying injury. And then we use a classification system based on the GCS, divided total brain injury into severe, which is a GCS of 3 to 8, moderate if it's 9 to 13, and mild if it is 14 or 15. All right, so that's how we look at the GCS and its predictive value on traumatic brain injury and classification. The epidemiology, we can see this is an older source now. I think this is a 2011 source, but I bet it hasn't changed very much. I probably need to update that. But anyway, you can see that falls 28%, motor vehicle traffic, struck or by against a car or another vehicle, assault 11%, unknown suicide 1%. These are all the leading causes of head injury. Males are twice as likely to experience a TBI as females, and the age distribution is trimodal, so it peaks at 0 to 4 years, 15 to 24, and then greater than 75. The elderly are, of course, like we mentioned just a second ago, at greater risk for death and poorer outcome, and we know our mortality will rise with continuous age. Motor vehicle crashes are the primary cause of blunt head injury in young adults and kids, and then falls are going to be more common in your elderly. And now those have exceeded motor vehicle crashes as the primary cause of TBI in the US. You can see that here at 28% versus just 20%. So this is an epidural hematoma. All right, I'll get my little pointer out here. Where are you? There you go. And you can see this what we call this classic football looking appearance. You know I'm a huge football fan. Go Knights. I'm a big Knight. And the classification of an epidural injury you often see with the appearance of this football looking lesion. Okay, you can see the blood accumulating there as well. So that's an epidural. This is a contusion or a hematoma. Okay, remember that liquid appears white on radiologic film, so that's why you're seeing white here. Let me go back. You're seeing all this white here, a little bit of gray matter there from the brain tissue, but you definitely can see blood accumulation right into the intraparenchymal space here. More of it here actually. Diffuse axonal injury. One of the things that you notice here in the CT film is, let me go back for a minute. This is probably better. Ignore the lesion here for a minute. You see these guys? These are called gyri right here. And then these are called sulci. Okay, so that's the actual fold of the brain tissue. And the hallmark of a diffuse axonal injury, which usually occurs from, like, for example, a coup, counter coup type of injury, so a motor vehicle collision where the patient had this significant brain shifting, you lose the sulci and gyri of the brain. See how this kind of looks all like it's diffuse and connected, right? Compare that, compare that to, sorry, I'm going the wrong way. Compare that to this. See how these beautiful, and this is I shouldn't say beautiful because it's still a brain injury, but look at these gyri and sulci that you can see here versus here. They're gone. See? That is your hallmark finding of a diffuse axonal injury, is loss of the sulci and gyri. Then there are subdural hematomas, which are a little bit more diffuse compared to the epidural. Remember, we looked at the epidural and it looked like a football. Subdural is not so much like that. It's more of like a snake that just kind of forms here in this subdural space. Remember that our elderly folks are going to be at more risk for subdural versus an epidural. And then this is diffuse edema, okay, brain swelling. Again, just like the diffuse axonal injury, you lose the sulci and you lose the gyri. All right, I wanted to break this down a little bit further for you. An epidural hematoma, this results from a tear in the middle meningeal artery. And this is beautiful because you can see this schematic here and compare it to the CT scan we just looked at, and you can see that it's exactly the same, right? And they say this kind of looks like a football. I think that here it probably looks less like a football than what we saw in the CT film. But yeah, tear in the middle meningeal artery, epidural hematoma. So the brain consumes about 20% of our total body output for O2 and about 15% of total cardiac output. The brain is exquisitely sensitive to ischemia and low oxygen states, and cerebral blood flow changes and adapts to the regional needs of the tissue. Under normal circumstances, microvascular changes in blood volume, pH, PO2, and PCO2 all regulate cerebral blood flow and really maintain us at an equilibrium between our oxygen delivery and then the metabolism within the tissue. But vasoconstriction with hypertension, hypocarbia, and alkalosis, obviously, that will occur. When you get hypertensive, hypocarbic, or alkalotic, you get cerebral vasoconstriction. Because it's difficult to measure cerebral blood flow accurately, especially regional differences and requirements, we look at cerebral perfusion pressure as a surrogate. And the CPP is the pressure gradient required to perfuse the cerebral tissue, and it's calculated as the difference between the mean arterial pressure and the intracranial pressure. So if you have an intracranial pressure monitor and you can calculate your MAP, you can calculate your cerebral perfusion pressure. So your MAP is going to be your diastolic pressure plus your systolic pressure minus your diastolic pressure and then divided by 3. And then you're going to subtract the ICP, and that will tell you what your CPP is. Remember, the normal ICP is between 0 to 15 millimeters of mercury. The local adjustment of cerebral blood flow within the brain, microcirculation, we call that autoregulation. Local cellular O2 demands can be met and regional cerebral blood flow maintained over a wide range of CPP, all the way up to 150 in a normal functioning system. But in TBI, autoregulation becomes impaired, and so cerebral hypoxia, even just a modest drop in blood pressure, can actually affect your cerebral perfusion. And so that's why when we look at CPP, the MAP plays a very important role, right? We just looked at the formula for CPP, and now we're talking how, we can see how that MAP plays a very important role in the overall CPP. An elevation in ICP will further reduce the CPP and inhibit cerebral blood flow as well. Because of the rich blood supply, the scalp has a major role in temperature regulation. So up to 50% of liberation of our body heat can actually occur in the scalp. So the same generous blood supply combined with loose areolar connection to the pericranium can lead to severe blood loss after injury. Remember that a scalp laceration will bleed, bleed, bleed. They can be very significant sources of bleeding. Because the basilar skull is the exit and entry point for the cranial nerves and blood vessels, basilar fractures are going to place those things at risk. So, what do? Assess the cranial nerves, right? Patient has a basilar skull fracture. You want to know the extent of it at presentation. Assess the cranial nerves. And like I said, in that autopsy I watched, I remembered, the examiner putting his fingers through the brain tissue at the brain stem and showing me all of the entry and exit points for the cranial nerves. It was really fascinating. The ionin is the anatomic meeting point of the frontal, sphenoid, temporal, and parietal bones, and fractures at that point can disrupt the underlying middle meningeal artery, and we already learned that if you disrupt the middle meningeal artery or lacerate the middle meningeal artery, it will result in an epidural hematoma, which is that classic football appearance on the CT scan. The cortex or gray matter contains the neuronal bodies, and the underlying white matter contains the axons, which transverse long tracts and connect to other brain regions and deep brain structures such as the basal ganglia and the major systems integration site. Which is the major systems integration site, I should say. The cerebellum occupies the posterior cranial fossa and is responsible for patterning motor memory and balance. And then, of course, we know our brain stem contain the cranial nerve nuclei, like we just mentioned, and our inflow and outflow of our functional somatic tracts. The arachnoid matter perforates the dura mater at the venous sinuses, where it forms arachnoid granulations, and these serve as filtration and drainage points for the CSF. The arachnoid matter is loosely adhered to the pia mater, which makes possible the potential subarachnoid space, and the pia mater is closely associated with gray matter of the brain and is the innermost layer. Remember that the pia mater is the soft matter. It's the softest layer of tissue. So between the arachnoid and the pia is the subarachnoid space, and that's where our CSF circulates. And there's about 150 cc's of CSF that surrounds the brain and spinal cord of adults, and about 500 cc's is produced by the choroid plexus of the lateral ventricles every day. And if you remember the name of the cells that produce that, it's called the ependymal cells that actually produce the CSF. The cranium, as we know, is an enclosed space. It's got a very fixed volume, 80% of which is the brain, 10% is the blood, and 10% is the CSF. Okay? Any changes in the volume of the intracranial vault will affect the ICP. Normally it's less than 15, and it's determined by the volume of those three compartments, so the brain, the CSF, and the blood. When one compartment overloads another, you get compensatory reductions in the volume of one of the others, or your baseline ICP increases. And this is called the Monro-Kelly hypothesis. Probably not so much a hypothesis anymore. Normal values for ICP ranges with age, with kids about 10 to 15, and then cerebral blood flow greater is generally maintained when the CPP is greater than 60. The level is considered the lower level of autoregulation, below which local control of cerebral blood flow cannot be adjusted to maintain flow adequate for function. So, in other words, a CPP less than 60 will result in a basically unstable autoregulatory response within the brain and an inability to maintain appropriate cerebral perfusion. Rapid rises in ICP may lead to Cushing's reflex, which we see hypertension, bradycardia, and erratic respirations being your hallmark symptoms. That triad is classic for an acute rise in ICP, but you only see it in about a third of cases. Severe and moderate TBI, which is where the GCS is 3 to 8 or 9 to 13, results from a complex array of cytotoxic and pathologic events. Primary injuries include contusions, hematomas, diffuse axonal injury, direct cellular damage, tearing, and shearing of tissue, loss of blood-brain barrier, disruption of the neurochemical homeostasis, and loss of the electrochemical functions. Secondary injury is damage caused by a series of deleterious cellular and subcellular events, so we call that the secondary cascade that follows the primary injury. It'll lead to an actual expansion of the initial injury. So don't confuse that term with secondary insult, which is used in the clinical literature to describe conditions or circumstances that are known to worsen the outcome of a TBI. So hypotension, hypoxemia, or an elevated ICP would be a good example of secondary insult, but that's different from secondary cascade. Cascade, remember, is going to be chemical. So things like calcium and ion shifting and mitochondrial damage, production of free radicals, and enzymatic activity that all lead to apoptosis. Disruption of neuronal connections can result in cell death of neurons remote from the injury due to loss of connectivity. So remember that secondary cascade is a chemical injury that follows the original or initial injury. So apoptosis causes ongoing tissue damage and has been reported to occur longer than a year after a TBI. Ongoing cellular damage, cytotoxic edema form within the cell from the loss of the cell membrane integrity and ion exchange, and extracellular edema, which results from the breakdown of the blood-brain barrier and alteration of aquaporins, which are proteins that are embedded in the cell membrane that regulate water flow and other water exchange mechanisms, lead to cerebral edema. And then elevated ICP can cause direct compressive damage to the brain, causing ischemia, obviously from compression of the vasculature. And then unfortunately, as this rises and continues to rise, we get herniation. There are three primary goals of the management of severe or moderate TBI: to prevent secondary brain injury, to identify treatable masses, and to identify other life-threatening injuries. Secondary brain injury is prevented or minimized by correcting or preventing hypoxemia, hypotension, anemia, hyperglycemia, and hyperthermia, and by evacuating intracranial masses. So things like hypotension of a systolic pressure less than 90 and hypoxemia of a PaO2 less than 60 have a doubling of mortality. Anemia with the hematocrit less than 30% can lead to increased mortality because of a decreased O2 carrying capacity, obviously. Airway control, C-spine stabilization, and assessment and support of breathing and circulation are always going to be your first priorities for all trauma patients. Pre-hospital is going to include stabilization of the airway and blood pressure and avoiding hyperventilation and use of capnometry, and treating hypotension aggressively. Administration of saline or lactated ringers is effective and safe. Reconstruct the mechanism of injury to determine the potential severity of injury in the ED. Look at the type of injury, the presence of other extracranial injuries like a spinal cord injury, or obtain details of the mechanism. How high were they? What kind of fall did they have? What was the impact surface? Leading body part for motor collisions? What was the vehicle speed? The type and damage sustained? Was there airbag deployment? Were they wearing their seatbelts? And was the windshield crushed? Obtain information about the patient's condition before and after the trauma. What medical history do they have? What meds are they on? Anticoagulants, for example, steroids, other things that might impact the recovery process, and possible drug or alcohol intoxication, which we know aggravates everything. Ask about other symptoms that can indicate increased ICP: nausea, vomiting, headache, memory impairment, and visual or auditory symptoms, all things that can lead to complications in recovery. So this is I think this is all. Okay, so I just added one more line there. The goal of ED resuscitation is to prevent secondary insult and potentially slow the expansion of your underlying injury. Patients with severe TBI of a GCS less than 8 require prompt airway control and orotracheal intubation using a short-acting induction agent that has a limited effect on blood pressure or ICP is performed, maybe a succinylcholine, for example. Avoid nasotracheal intubation if the patient has severe facial trauma. or a basilar skull fracture, and pre-induction agents are not beneficial. And let me get my pointer. Okay, so this is a real picture. This is not a horror movie. I wish I could tell you it was, because I'm going to stay strong, but usually when I look at this picture, it breaks my heart and I cry, because I can only imagine the trauma this poor man went through. You probably know this story. This is an elderly man. I can't think of his name off the top of my head. I should know his name. This man was attacked. I think he was homeless, and he was attacked by a man who was high on bath salts. And this occurred down in Miami. And basically, this guy that attacked him was killed by police officers. The man was naked, and he cannibalized this man. He actually bit into his face, ripped flesh off of his face. It's just heartbreaking to me that something like that could happen to somebody, that somebody could be a victim of this. This man has gone on to require countless reconstructive surgeries. And you can actually Google this, and I don't think I have a picture of what he looks like now. I probably should have put one in the slide for you. But this man is permanently deformed because of this. I believe he is blind in both eyes. I think he eventually lost this eye, if I'm not mistaken. I might be wrong on that, but I think he did. You can see that he has no nose. I mean, it is awful. Awful situation here. Of an awful facial trauma. Patients with severe TBI of a Glasgow less than 8 are going to require prompt airway control. Etomidate is actually, I said sucks, I apologize, but etomidate is a good choice. It's delivered at 0.3 milligrams per kilogram. It has a rapid onset of action, about 45 seconds, short duration of action of 3 to 5 minutes, and a good hemodynamic profile. So I apologize, I said succinylcholine earlier. Those are preferred neuromuscular blocking agents because they're short acting, but there's no long acting that we want to go with because of neuro effects of succinylcholine. So, again, if you're going to, so I guess I was right. Sux is actually partly right, but etomidate is a great choice as well. And then propofol or Diprivan at 1 to 3 mg per kg through IV has several potential benefits. As an induction agent, it has a rapid onset and recovery, strong anti-seizure properties, and the other thing is it has a very short half-life, so you can stop it and wean the patient if you need to. Boluses of propofol can cause hypotension and should be used with caution in patients with labile blood pressure or who have inadequate fluid resuscitation. So that's one thing that's very important about Diprivan, is that we don't often think about the effect that it can have on blood pressure, and we have to rapidly intubate somebody that's got trauma. Yes, you might use Diprivan as a sedative agent, but it can actually cause them to have lower blood pressure, and if they're already hypoperfusing, that can be an issue. Hypotension and subsequent ischemia of vulnerable and injured neuronal tissue can dramatically exacerbate injury, and it can exacerbate the underlying secondary cascade. So we talked about the secondary cascade with brain injury and how that involves those cytotoxic chemical reactions, and then what happens as a consequence? Yes, we get an expansion of the original injury and worse outcomes. In severe TBI, a single episode of hypotension will double mortality, so fluid resuscitation needs to be aggressive to prevent secondary brain injury. It does not increase ICP, and there are guidelines that recommend that we aggressively maintain the systolic pressure at greater than 90. All right. There are no specific recommendations for MAP. However, most studies report we want to keep the MAP greater than 80. So your two key takeaway points there: keep your systolic pressure greater than 90, your MAP greater than 80. All right. The other thing we said before is that MAP is used in the calculation of cerebral perfusion pressure, and we talked about the important role that the MAP has in maintaining CPP. And if the CPP drops less than 60, then autoregulation within the CNS becomes impossible. If fluid resuscitation is not effective, then we've got to turn to our vasopressors. So if the MAP drops below 80, it's time to go to, for example, Levophed or another option. Control external internal bleeding quickly. Maintain the hematocrit greater than 30%. Like we mentioned before, severe anemia significantly impacts mortality. GCS neuroassessment, because many factors inhibit the full use of the scale, like facial trauma and intubation, we only usually get to monitor the motor component. In an unresponsive patient, a single fixed and dilated pupil, which is called anisocoria by the way, may indicate intracranial hematoma with uncal herniation that requires a rapid operative decompression. So we need to consider direct ocular trauma as another cause of pupil dilation. Bilateral fixed and dilated pupils can, like I mentioned before, suggest increased ICP and poor brain perfusion. And bilateral uncal herniation, which remember is where you basically the brainstem is being shoved down the foramen magnum, drug effects or severe hypoxia. Bilateral pinpoint pupil suggests either an opiate use or a pontine or pons lesion. Altered motor function can indicate brain, spinal cord, or even peripheral nerve injuries. In an unresponsive patient, like we said, uncal herniation with that single fixed dilated pupil. Movement in unresponsive patients may be assessed by observing reactions to noxious stimuli. So you might put pressure on the nail bed, or if the patient doesn't have a chest trauma, you might do like a sternal chest rub and see if they respond to that. Decorticate posturing is where, remember, the body, the upper extremities go into the core of the body. Remember, decorticate, the core, indicates severe intracranial injury above the level of the midbrain. And then decerebrate posturing is where you get the fingers pointing to the cerebrum, okay? So they actually point to the cerebral part of the cranium. Now, this indicates a more caudal injury, and I know you've been taught in your undergrad level that decerebrate posturing is so much worse than decorticate posturing. Let me tell you something. If your patient is posturing, they're probably going to die, okay? Doesn't matter if it's decorticate, doesn't matter if it's decerebrate. It is a very ominous finding of increased ICP as a consequence of brain lesion, all right? So it's not a good finding whatsoever. If that TBI patient is uncooperative or combative, intubation and sedation is often our best option. If they're greater than 65, coagulopic, or if they have a fall greater than 3 feet or down 5 stairs or more, or their GCS is less than 15, obviously we're going to get a CT scan. 15% with GCS have a 14 or 15, and they do have lesions on the brain CT. A majority of episodes of mild TBI do not result in loss of consciousness, and loss of consciousness is not the best predictor of intracranial pathology. So remember, like I said before, guys, your neurologic exam here is going to start with your mental status exam, alert and orientation ×4, your cranial nerve assessment, which we already went through. I told you how to assess all 12 cranial nerves, followed by your motor function in your upper extremities and your lower extremities, and then finally your sensory function of these areas as well. You're not going to apply the Canadian or New Orleans rules on patients who are on anticoags. Nausea and vomiting after concussion has an odds ratio comparable to that of loss of consciousness for positive CT findings. And CT imaging of the C-spine should be considered in patients who have altered mental status and who are injured by a mechanism that increases the risk of C-spine injury. And those are taken at the same time the patient has a head CT. ICP greater than 20 will subsequently predict morbidity and mortality. Indicators of increased ICP are going to be things like headache, nausea, vomiting, seizure, lethargy, hypertension, bradycardia, and agonal respirations. And these last 3 things here you should be recognizing as your Cushing's reflex or Cushing's triad. Signs of impending transtentorial herniation include unilateral or bilateral pupil dilation, hemiparesis, motor posturing, and progressive neurologic deterioration. And if the patient has evidence of increased ICP, they should be carefully ventilated. You want to keep their CO2 between 35 and 40 and their O2 saturation greater than 95%. Adequate sedation is important and helps decrease ICP by keeping the patient relaxed and eliminating their gag. Elevation of the head of the bed to 30 degrees to increase outflow of CSF from the skull base, or doing a reverse Trendelenburg position if they have a spinal cord trauma is all going to be significant. And you can see from this slide what reverse Trendelenburg looks like in a patient. Mannitol is an osmotic agent that can reduce ICP and improve cerebral blood flow, CPP, and brain metabolism. However, we learned in critical care pharmacology last semester, or whenever you took it, that we do not give mannitol to patients with bleeds. So if the patient has a bleed in the brain, then we never ever give mannitol. Other benefits: it's a free radical scavenger. It reduces ICP as quickly as 30 minutes, and the effect is a little bit variable of up to about 8 hours. It expands plasma volume. It initially reduces hypotension and can improve O2 carrying capacity. It's administered by a repetitive bolus, not by a constant infusion, and the result is a net intravascular volume loss because it does have a diuretic effect. So we do need to monitor their input and output and maintain euvolemia. Hyperventilation is only indicated if herniation is immediate. Steroids are not indicated, so we wouldn't want to use, for example, methylprednisolone in these individuals. It's actually associated with increased adverse outcomes, so we don't want to use steroids. ICP monitoring should be initiated if the patient has a Glasgow Coma Scale less than 9, or if there's evidence of herniation on the CT. If CSF drainage is not effective in reducing ICP, continued medical therapy, such as that mannitol we talked about, maybe even using hypertonic saline, all are things we're going to do assuming that the patient has an adequate MAP. For scalp lesions, like I mentioned before, scalp lesions can be very bloody. They can hemorrhage quickly with scalp lesions. Direct pressure can oftentimes not be effective, so you've got to infiltrate the area with lidocaine infused with epinephrine. And if that's not enough, they even may need vessel clamping. Careful wound exploration of the scalp is needed to identify foreign bodies, deformities that might suggest fracture as well. A linear skull fracture with an overlying lac is considered open, and you want to administer vancomycin 1 gram IV and Rocephin 2 grams IV, provide a tetanus prophylaxis, and obtain a neurosurgical consultation immediately. Particular care should be taken in evaluating fractures that cross the middle meningeal artery. Why? Hopefully your brain is right now thinking, because, Dr. Blackwell, that causes an epidural. That's right. Or a major venous sinus. Linear occipital fractures are also associated with high intracerebral complication rates. The most common basilar skull fracture involves the petrous portion of the temporal bone, the external auditory canal, and the tympanic membrane. It's associated with dura tears and can lead to otorrhea if it's posterior, or rhinorrhea if it's anterior. Signs and symptoms with basilar skull fractures we already talked about, but also things like hemotympanum, vertigo, decreased hearing or deafness, and seventh nerve palsy. So again, assessment of your 12 cranial nerves, crucial. Fluid may be collected and sent for analysis, which will identify transferrin. Transferrin is only occurring in your CSF, not in blood, mucus, or tears, so you don't have to worry about that coming up as a false positive. If there's transferrin there, it is in fact CSF. Okay, look at this picture here and you can easily identify two of the hallmarks of an anterior basilar skull fracture. The first one being raccoon eyes, okay? The second one being rhinorrhea. Leakage, which again looks bloody, right? Looks a little pink here. Assessment for transferrin would tell us whether or not this is CSF or is this blood coming from nasal trauma. You can see this guy looks like he's got a broken nose here as well. I mean, you can see that it's shifted. Definitely abnormal. Not good for this guy. Posterior basilar skull fracture is seen here. This might be a kid, I'm not sure. But nonetheless, look at this ecchymotic region here of the mastoid. This is called battle sign. Okay, that's a battle sign. Uncal transtentorial herniation leads to compression of the parasympathetic fibers running within the third cranial or oculomotor nerve. So you get an ipsilateral fixed and dilated pupil, and that's called anisocoria. Further herniation compresses the pyramidal tract, which results in contralateral motor paralysis. So if you've got right-sided paralysis, for example, you know that herniation is occurring mostly on the left. Central transtentorial herniation, less common and occurs with midline lesions in the frontal or occipital lobe or in the vertex. Most prominent symptoms are going to be an initial bilateral pinpoint pupil, bilateral Babinski signs, increased muscle tone, fixed midpoint pupils following along with prolonged hyperventilation and decorticate posturing. Remember that Babinski sign is where you take the tongue depressor, I should say, and you stroke the foot from the heel to the toes. And normally you should see an inward movement of the toes, a flexion of the toes, and instead with a positive Babinski you get fanning of the toes where they spread apart. That would be ominous. Cerebrotonsillar herniation occurs when the cerebral tonsils herniate through the foramen magnum. Pinpoint pupils, flaccid paralysis, and sudden death. Upward transtentorial herniation results from a posterior fossa lesion, leads to conjugate downward gazing and absence of vertical eye movements and pinpoint pupils. Intracerebral hemorrhage can occur days after significant blunt trauma and often at the site of resolving contusion. It's more common in your patients with coagulopathy, all right? Patients with isolated traumatic subarachnoid hemorrhage may present with headache, photophobia, and meningeal signs. So neck rigidity, for example, neck pain. Traumatic subarachnoid hemorrhage is probably the most common abnormality in patients with moderate to severe TBI. The classic history of an epidural involves a significant blunt head trauma with loss of consciousness or altered sensorium, followed by a lucid period and subsequent rapid neurologic demise, but this clinical pattern occurs in a minority of cases. And if you think about it, one of the most famous cases, I don't know if you know Natasha Richardson, that was the wife of Liam, what is his name? Oh gosh, I'm drawing a blank right now of the guy that is in all the action movies like Taken, Liam something. Let me look him up real quick because it's driving me crazy. Let's see here. Liam Neeson. Thank you, Jesus. Liam Neeson. His wife, who I know because I'm a huge Broadway buff, played the role of Sally Bowles in Cabaret, and I believe she won the Tony for it. This happened to her. She died of an epidural. She slipped and fell during a skiing accident. She had a loss of consciousness. It was very rapid. She then all of a sudden came to. People said, I think you need to go to the hospital and get looked at, Natasha. And she said, no, I feel okay. I feel fine. She went back to her hotel, went to sleep, and died. And that is your classic epidural death. So patients need to be very, very careful. If a patient has this period of lucid activity, then this could be indicative of that patient with an epidural. On CT scanning, an epidural, like I said, appears like a football in the temporal region, and death can occur within hours, but if they evacuate it early, the patient can actually have a full recovery. Breaks my heart that Natasha Richardson didn't go to the hospital because if she did, then they could have probably saved her. And she was a very talented woman, and we'd be able, bless you, my little Jack Russell just sneezed. You probably heard her sneeze. Did you sneeze? Yes, you did. But anyway, she could have lived. Subdural hematomas are caused by a sudden acceleration deceleration of the brain parenchyma with tearing of the bridging veins. And this results in that hematoma formation between the dura and the arachnoid space. Or the arachnoid matter, I should say. Blood tends to collect more slowly than in an epidural, and that's because remember that an epidural is a tear in the middle meningeal artery, and we know arterial pressures are higher versus an epidural, or versus a subdural, I should say, which is more of a venous trickling, okay? And subdurals are dangerous because oftentimes with a subdural hemorrhage, the brain will actually clot off, the hemorrhage site will clot off, and so the patient will have a negative CAT scan because they're not actively bleeding at that time, and the only way you can really diagnose that is to get a lumbar puncture, and you'll see the presence of red cells in the actual CSF. So brains with extensive atrophy, so your elderly or alcoholics, they're going to be more susceptible to subdurals. Acute cases, which are less than 2 weeks, usually present immediately after a trauma, and the patient is usually unconscious. Chronic subdural hematomas are those that last more than 2 weeks. They occur in your elderly or your alcoholics. They complain of vague complaints of mental status change, and you'll usually see a hypodense or darkened area on the CAT scan, and that's because iron in the blood is phagocytized, and so on the film you'll see this as a very dark hypodense area. So that's a chronic subdural versus your acute case of these presentations. Classically, a diffuse axonal injury is seen after a blunt trauma, and we already looked at the CAT scans for all of these, so just look back and think back. But with diffuse axonal injury, the CT usually shows a punctate hemorrhagic injury along with a gray-white junction of the cerebral cortex and the deep structures. Remember, we looked at that CT scan, and you saw that the gyri and the sulci were really kind of gone. They were meshed together, if you will, in a diffuse axonal injury. You see that same finding in diffuse edema as well. As a bullet passes through the brain, it creates a cavity 3 to 4 times larger than its diameter. So patients with that GCS score greater than 8 and reactive pupils after a gunshot wound have about a 25% mortality, and then that approaches all the way up to 100% when the GCS drops below 5. All patients with a penetrating gunshot wound to the brain should be intubated, treated with prophylactic antibiotics such as ceftriaxone or Rocephin at 2 grams given intravenously. For mild TBIs and sports-induced concussions, the diagnosis of mild TBI essentially rests on the history surrounding the injury and any alteration of mental state at the time the injury occurred. Amnesia can be a sign of serious injury. Many patients with mild TBI experience an initial objective neuropsychological difficulty involving memory, attention, and executive functioning. Depression is a common secondary complication, and some patients have residual persistent subjective cognitive complaints that disrupt their social relationships and their ability to resume normal activities. I remember my dad's partner's brother was involved in he was a race car driver, and he was involved in a TBI. I don't remember the specifics of what happened to him, where I could tell you what area of the brain was involved, but I know he did have extensive frontal lobe damage, and he had a completely different personality after he had the event. He used to be a very gracious person, very kind person, and he became a very stingy, nasty human being that eventually went on to develop dementia. And I remember he was in the nursing home, and he had taken a razor blade and was actually brushing his teeth with a razor blade and sliced his tongue, lacerated his tongue, his gingival tissue, and ended up having to go into like emergent oro surgery as a consequence of that. Bless you, that was not my dog, that was my partner sneezing. Repetitive concussions can result in long-term cognitive deficits and structural brain damage. So then a second concussion can occur prior to the recovery from the first, resulting in a rapid onset of cerebral edema and death. And you see this in athletes who are, for example, a football player that gets hit in the head. The athletic trainer will do a rapid assessment of neurostatus, say, they're fine, put them back in the game, and then they die. Currently, there are no reliable tests. Well, they get injured again, and then that's what causes their death. Currently, there are no reliable tests that can confirm a diagnosis of concussion, so typically you see this just with history finding. Physical exam might find an isolated mild TBI with documentation being very important, that a full exam was done looking for clues as to severity of mechanism of injury and resulting neurologic impairment. Focal findings are rare and suggest potentially significant intracranial pathology, and the patient should also be assessed for signs of global impairment such as confusion, perseveration, amnesia, or other findings, and results should then be recorded. And perseveration, by the way, is a repetitive speech pattern or repetitive movements or activities. You often see it with autism, but in this case we're talking about it in terms of traumatic brain injury. Symptoms that require immediate follow-up include headache, emesis, weakness, numbness, dizziness, decreased concentration, memory problems, sleep disturbances, irritability, fatigue, visual disturbance, judgment problems, depression, and anxiety. The Graded Return to Play recovery program was specifically developed for athletes, so those who continue to have symptoms longer than 3 weeks should seek follow-up with a qualified health provider who has experience with treating TBIs. The most common symptoms are headache, difficulty concentrating, and short-term memory difficulties. The treatment of symptoms include rest, including brain rest, and therapies targeted at specific symptoms like NSAIDs and hydration, but of course no aspirin. The most commonly reported post-concussive symptoms are going to be headache, dizziness, decreased concentration, memory problems, sleep disturbance, irritability, fatigue, visual disturbance, judgment problems, depression, and anxiety. An examination of gait or balance challenge is needed because that would indicate cerebellar disorder, and disorders of the cerebellum can be quite serious. However, the most consistent abnormalities are going to be subtle impairments in cognitive function. When symptoms return with cognitive or physical exercise, it is a warning that metabolic disturbance is occurring, and therefore cessation of activity is going to be advised, including a reduction in the level of activity. All right. Whew, that was a very long lecture, and that was only the first part. So I apologize that there is such a massive amount of content in this particular unit. But that concludes part 1 of a 3-part narrated PowerPoint series covering trauma. At this point, I would encourage you to probably take a break. You probably have to pee at this point. So I would go pee. I would probably get a drink, maybe an alcoholic beverage. Just kidding. And do whatever you need to do to regain your focus. So that concludes part 1. Please access part 2 and 3 at your convenience. Again, my name is Dr. Christopher Blackwell. I'm an associate professor and acute care nurse practitioner and program director for the Adult Gerontology Acute Care Nurse Practitioner programs here in the College of Nursing's Department of Individual, Family, and Community Health Nursing. Hope you have a wonderful day. Thank you for your patience. God bless. Bye-bye now.